All right. Well, good evening, everyone. Thank you, everyone, for being with us. Thank you, Sherri, and your band for keeping us entertained there. I'd like to welcome everybody to our VCSQI Summer 2024 quarterly meeting. Thanks all for being on the line with us. We are just going to jump right in because we have a jam-packed agenda and we want to make sure folks are able to leave on time tonight as well. So just a couple of quick housekeeping pieces. I think you're all familiar with Zoom at this point, so we don't need to spend too much time here, but the most important piece is this is an open Zoom meeting, so please feel free to jump in any questions, comments you have, unmute, type in the chat box. You can even text Sherri or myself if you'd like to. Your interaction is not just welcome, it's encouraged. We need you all to participate for these meetings to be a success. So thanks so much in advance for your participation and engagement. Sherri, do you want to share a little bit about the CME opportunities that are available tonight?
Absolutely. We have recently transitioned our vendor for CME credit. We understand that the prior platform was not as user-friendly as we had hoped, and we wanted to create an opportunity for you to get as much credit as possible by attending these amazing meetings. So recently, we had a meeting with UVA, and we transitioned our CME services under their CME department. So now, by participating in this meeting, everyone, if you qualify, will be offered attendance or credits for AMA, Category 1. We have nursing credits. We have physician assistant credits. We have the IMPCE, performance improvement credits. And we also do have the ABMS, maintenance and certification, Class 2 award. So if you are interested, in the next slide, we will show you how to obtain your credit. Of course, there's two parts. One is claiming your attendance, and two is completing the evaluation. Here's the information that you will need. Please note that we will send this recording to you as well as the slide deck so you can claim your credits after this meeting. The window will be open for you for 3 weeks. So please take advantage of these credits. And if you're interested in us offering additional credits, please let us know.
Thank you, sir.
Bye. Right. Okay, that's all the updates I have. I hope this experience is great, good for you, but always we aim to please. And if there's any recommendations of improvement that you may have, please let us know.
Thanks so much, Sherri. We'll just leave it here for a quick second if folks want to take a screenshot or scan the QR code here. And as we mentioned, we'll be sure to send out these slides afterwards as well, including this little info piece on how to claim the credits. So tonight's agenda, we will feature our chairman, Dr. Cotter, who will provide some updates from the board as well as updates on a recent research project that we have been working on efficiency in the cardiac OR. We'll also hear some QI updates from Sherri, our wonderful quality improvement advisor. We'll present some data from our VCSQI database. And last but not least, we will have a keynote from Dr. Kontos, who will present information on ACC's latest trials that are likely to affect clinical practice. So as a quick intro here, this is our VCSQI strategic plan with our mission to transform cardiovascular care to improve patient experience and value, and our vision of optimizing heart care outcomes through national collaboration, innovation, and research. And we will try and center everything around these key strategic building blocks this evening. So I know Dr. Cotter texted earlier, he said he is still with the patient, I believe. So we are going to switch up the order a little bit, and Sherri will pass it to you for some QI updates first.
Thank you very much, Eddie Fonner. Fonner, I appreciate you. Thank you for attending our meeting tonight. And I just wanted to give everyone let everyone know what's going on. We have a lot going on in our collaborative, and I'm proud to say that. So let's just look at some work groups that we have going on. So I categorized this slide for you to see every work group that is broken down by collaborative. And I'll remind you, we have several collaboratives under VCSQI or in collaboration with another collaborative, if you will. So for VCSQI ourselves, of course, you know, we focus on surgery and cardiology. So we have several work groups. We have our CATH PCI, which is our cardiology data managers. We have our quality committee, which is our STS data manager. And our champion for that work group is Judy Smith from UVA, who we all know and love. Research and writing, proud to announce that Dr. Provenza is the new chair of this work group. The work is being transitioned from Dr. Tiemann, who is leaving on to greater opportunities. And so Dr. Provenza has greatly accepted and taken on the championship role for this work group. Of course, we have our DEI 2.0, and this has many leaders, champions, I would say. We have Halima and Judy, both from UVA, and Charmaine McCoy from ANOVA. Of course, they may not know that they're champions, but they provide a lot of research or input into this work group to help it as dynamic as it is. And I'll provide some additional insight on that specific work group later. Of course, we have our perfusion work group that is led by Eve Dallas from UVA. Thank you, Eve, for all you do. Eve has gave a few presentations during our quarterly meeting, highlighting a lot of different metrics that were developed exclusively for our perfusion group. Of course, we have our AKI, which is led by Mike Brown from Mary Washington, Shelley Callahan from Centera, Judy Smith from UVA, and our beloved Chris Seitzma from Winchester, who has recently retired. The AKI work group has developed a set of guidelines that is available to us all on our VCSQI website under the menu item that says protocols. And of course, we have our readmission work group that is led by Dr. Lancy from Centera and Andre Talares from VHHA. We have recently developed a set of recommendations for this specific work group. That is available to you as well on the VCSQI website under protocols. And this set of recommendations also come with an amazing calculator that helps you to predict the risk, either low and immediate or high risk of readmission, and also provides a slew of recommendations to help mitigate that risk. So please check it out. If you're interested in joining any of these work groups under VCSQI, please give me a call, shoot me an email, or let Eddie know, and we'll be happy to sign you up. So under VHAC, it's almost been 2 years since we merged with VHAC, but VHAC is an amazing collaborative as well, focusing more so on heart attack, STEMI, areas of that nature, TVT. And so we continue to grow. We have our steering work group, which is a meeting that takes place monthly that is headed by the co-champions or the founders of the organization, which is Dr. Peter O'Brien from Centra and Mike Kontos from VCU. This year, we wanted to do a little bit more, kind of mimic some of the things we're doing within VCSQI, which is work groups. This is how we excel. This is how we create best practices coming together to explore different ways that our collaboratives or partners or members are doing and coming together to create a standard set of recommendations or enhanced protocol. So under VHAC, we have a series of work groups. We have ECG education that is led by Bob Page, who is an educator within Virginia. And we have Sherri E. Moore from Carilion, who are leading this charge. We also have thrombolytics work group that is led by John Patterson. The PowerPoint, let me just pull this back up.
Sorry about that, Sherri.
Oh, you're fine. I'm working on it as well, Eddie. Okay, almost there, everyone. Okay, and it's only on screen. I'm sure. This is just testing my technical skills. I wish I had music during the time, but next time I will sing. I have it up. So we have our thrombolytics head by Dr. Patterson. and Robert Constance from HCA, and of course, Mike Kontos from VCU. We have our PE response team, also referred to as PERT. And this is led by Mike Kelly from Carilion and Jessica Mountjoy from Mary Washington. We have our ED bypass and false activation work group led by our founders of VHAC, Dr. Peter O'Brien and Dr. Kontos. And we have just reignited our shock work group. A meeting will be scheduled, or the kickoff meeting will be scheduled later this month. But this initiative is being led by Dr. Berzingi and Dr. Joseph of Carilion. Now, either of these work groups, the goal is to actually create a set of recommendations, tools, metrics, resources to share across the state. And again, if you're interested in joining any of these work groups, please let me know. And last but not least, while we work to improve the care of our patients across the state of Virginia, we have taken upon ourselves to work with other collaboratives across the state to take the work that we do more so on a beginning of a national basis. And so this is a part, or what we call the Perfect Care Impact Network. And so this includes Perfect Care, which is a collaborative within North Carolina that includes Atrium Health, Johns Hopkins, and a few other hospitals. This also includes VCSQI, which is a Maryland collaborative. They focus specifically on surgery. And then also we include VCSQI, a part of this collaborative. Within this network, there's 4 different work groups that we are working on. Of course, we have our goal-directed perfusion, again, led by Eve Dallas from UVA and Terry Haber, who is a part of VCSQI. We have goal-directed therapies, which is led by Amanda Ray and Sharon Crotwell. Actually, Amanda is from VCSQI and Shannon is part of Atrium Health through Perfect Care. And we have our readmission and AKI work group, led by Shannon Crotwell from Atrium/Perfect Care. And we have our data integration work group, which focuses more so on what we could do within Epic and looking more so deeper into the data to create a summary level of recommendations or metrics that we can share and benchmark against one another. And later on during our presentation, Eddie is going to highlight a few of those slides for you. And of course, this is being led by Eddie, Judy Smith from UVA, and Diane Alejo from Johns Hopkins, who's leading this charge. And so I will pause and if you have any questions about any of these work groups, please let me know. Okay. More information will be shared about these work groups via email and also posted on our website. But if you have any interest in joining any of these work groups, please let me know. Reach out to me directly at Sherri at VCSQI or let Eddie know and we'll take it from there. So at this time, I wanted to highlight a few of our work groups. I wanted to take the moment to highlight the work we are doing within our DEI work group. This slide actually does not contain many words, but instead it contains graphics. I think this was a better representation of the work that we've been doing within the work group because DEI is a path that has so many different elements, it touches so many different lives and it touches so much, so many aspects in healthcare. So this slide, I hope, captures it all. So a few things that we've been working on within this work group is just focusing on our path to discovery. So right now we have been discovering what is DEI and defining it and discovering best practices, what initiatives, who are taking or doing the initiatives or the work in DEI within their organizations. We have met with a few hospitals within Cleveland who shared their practices and shared with us their social determinants of health questionnaire, and also how they integrated it within their Epic system. We have met with an organization called Unite Us to understand the resources and how we can connect healthcare to external resources to help bridge those gaps and disparities of care. We have had a wonderful presentation from ANOVA highlighting the work that they do actually within the community to help bridge the gap in disparities of care. And that includes just going out into communities, helping to educate everyone on the risk of heart attacks, hypertension, things of that nature that will impact health. And overall, our goal for this work group is create a repository of resources, best practices, and tools to help everyone help our community live a fruitful and equitable life. And I will pause if anyone has any questions about this specific work group. Okay. The next work group I wanted to highlight, we actually met a few days ago. This work group is under the umbrella of the Perfect Care Impact Network, and specifically this crosses Virginia State, Maryland, and also North Carolina. So this is a collaborative of 3 states. This specific work group is called the Goal Director Perfusion Work Group, also again led by Eve Dallas. But I just wanted to throw this out for everyone. If you're interested in participating in this collaborative, working to help improve practices for perfusionists, understand different perspectives that may impact, excuse me. I'm sorry, I guess, and I don't think anybody ever had that happen. But to improve perfusion practices for our patients. If you're interested in joining this work group, please do not hesitate to reach out to me. The next meeting will be scheduled for July 2nd. And at that time, we're going to meet with Melinda Culper, who is a part of Atrium Health, who's going to share the practices that they have in place, pretty much different factors that affects CO2 and AKI. So if you want to learn about what they're doing and learn more about this work group, please attend. I will add this to our website, or feel free to reach out to me directly, and I will invite you to this work group and or meeting. Now I'll pause for any questions. Okay, up next,
Sherri,
we have, yes.
would it be appropriate for folks who are on the call to invite perfusionists at their organizations to join this group?
Absolutely. Great question. Yes, indeed. If you have perfusionists who will want to be a part of this work group, please send them my way and I will be happy to add them. So yes, one of the goals for their work group is to include more participation from perfusionists. Great question. Thank you so very much. And I see Eve is on the line as well. Before I proceed, Eve, is there anything else you wanted to add that I may have missed?
Yes, please. All the perfusionists. We want all of them. Thank you.
Love it. Any other questions, actually? All right. And also, if there's any work groups that you would like for us to initiate or start, please let us know as well. We will do our best to get it started. But on the screen right now, I have a reminder, our MACPAC angiogram film reviews. We've been doing film reviews for, I want to say, over 5 years now. We transitioned from ACE to MACPAC, which is, I cannot remember what it stands for, but they're a part of Johns Hopkins, and please forgive me for not remembering what the acronym stands for. But we run a quarterly report, if you will. If you're interested in participating in this, we will do an analysis of all your PCI cases that are entered into the system, and we will de-identify them and send them over to our MACPAC team. They will then take that list and randomize it down to at least 5% of cases. And typically for each operator you have, their goal is to take perhaps 2 cases that the operator has performed and evaluate them and assign them to a licensed reviewer. the reviewer would then assess it for appropriateness, the level of stenosis, and add additional comments as it relates to how what they may have found that can help treat the patient, if you will. However, you are more than welcome to opt out any comments from the reviewers, but we have found that several of our members use this to identify best practices, to evaluate the contracts volumes, and also use this for accreditation for ACE. So if you're interested in participating in this project or this initiative, please let me know. And at a future meeting, we will have one of our members who actually use this project or to help them to achieve accreditation through ACC. So stay tuned for more. Okay, and last but not least, actually, I think I have a couple more. Last but not least, we have a couple of planning committees that we wanted to highlight and announce. Arranging these meetings, we put our heart into it, and we want to make these as valuable as possible for everyone that we serve, and that is our cardiologists, our perfusionists, our surgeons. So it takes a little bit of detail, and we want to make these, again, more valuable for you. So this started with VHAC. VHAC has their upcoming statewide meeting scheduled for September 26th. During this time, we wanted to explore the possibility of having a 2-day event. And what should we do? What type of presentations or workshops could we offer? So highlighted on this list, we have several members who are actually helping to plan our September meeting for VHAC. And we want to do the same thing for VCSQI. How can we make our quarterly meetings more valuable for you? So on the screen is a QR code if you want to scan with your cell phone. But again, I will send this out to you via email if you would like to fill out the survey or the form to sign up for the work group. Again, we hope that it'll be minimal work, maybe meeting once or twice a month, depending on if it's VCSQI or VHAC, but we want to create a program or a meeting that is more valuable for you. So sign up. And actually, do you have any questions? Hope I'm not going too fast. Okay, and almost there. So in the chat, there are several links, and all the links are listed in the chats for these specific surveys. So within VHAC, we have our thrombolytics work group who has a survey to assess your current practices. If you have not completed that survey yet, please take the moment to do so. We have our Perfect Care Network who has recently launched a drainology survey, again, to assess current practices. Here's the link here, but I also included it in the chat. Our PE response team, aka PERT work group, also has a survey to assess current practices. Here's the link that is also included in the chat. And also one of the most exciting work surveys, and they all are exciting, but we're looking to evaluate the resources that are put into our cardiology registries. How much time does it take for our data managers to extract? And we want to come up with a set of recommendations that we can offer to each of our members. So if you have not participated in the survey yet, please take a moment to do so. We just want to see how much time, and it would be better for a data manager to complete this survey so we can appropriately track the amount of time that they spend for easy charts versus a more difficult chart and other tasks that they may do as assigned to their role. And I will pause again for any questions you may have.
Just to jump in, Sherri, we will share all the results of these ongoing surveys as well with the team on our mailing list as well as on the website.
Thank you, Eddie. Okay, moving on to our next slide. So I wanted to let everyone know to expect some remodeling of our website. We've gotten feedback about the structure of the website, and we really appreciate it. We want it to be as easy to navigate for you as possible. So our members portal will be redesigned to call forth or make it easier for you to find the metrics that we share and also different resources that may help you in your practice. Also, I wanted to announce that many of our teams are being converted over to Teams in Microsoft, utilizing Microsoft Teams. This will help us on a communication level. We want to increase or enhance communication for each of our work groups, as well as operationally, this will help. We do want to point out that we are taking account that not everyone may not be able to utilize Team, may not be as familiar with Teams, or may not even like Teams. So we are working on building out an alternative, if you will, on our website. And so within the team sites, there's an opportunity to chat. There's an opportunity to share files. We will also have a link on our website under the members portal for each work group that would also give you a different entry point, if you will, to those features. So more to come. And please let us know how you feel about these transitions. We hope they are helpful. And last but not least, I wanted to point out on our members website or on our VCSQI website, you have the opportunity to update your profile. And if you could, please go in and update your profile because it would help us to target communications. I know that sometimes you may receive a email blast for surgery or for cardiology, and you may not do either. Indicating which registry you're a part of and even your title and your organization would help us to filter those email blasts. So take a moment to do so. Just go to the VCSQI website, sign in at the top where it says login, click on profile, and then it will open up another window for you where you can click the edit button and update your profile. You can also include information about yourself. Is there anything that you want to share for other members that you would like for them to know? Insert your credentials. And also you have the opportunity to follow other members and you can update your profile or have any updates as well so our members can pretty much, it's like a Facebook, if you will, within VCSQI. So we hope that this tool is useful to you, and please let us know how we can improve on the work that we do. And actually, Addie, that is the last slide that I have. I will pause. Does anyone have any questions, comments about anything I just presented? I know it was a lot. I'm sorry.
Thank you so much, Sherri. Great job as always. And please, everyone, feel free, just let us know how we can help, how we can best get the information out. We're trying to make it available on multiple different ways. So if Teams doesn't work, it'll be on the website, or we can always just email it. So just whatever works best. We just want to make sure info is available. We're democratizing access to all of the good resources that our members help us create and share. So thanks so much for the update, Sherri, and looking forward to working with everyone on all of these exciting projects. So up next, I would like to welcome Dr. Cotter from VCU, who is our VCSQI chairperson. Dr. Cotter, can I call on you for a couple quick highlights from the board and then some updates on your most recent research that you're doing?
Please do, Eddie. I'm so sorry, folks. I just was in the middle of completing a surgery. I'm still around the workplace, so if you hear any voice in the background, apologies. So go ahead, Eddie, if you want to update things. Yes, so a couple of important announcements that I like to just bring it to your attention, that there has been some change in the previously elected leadership person. As you all know, that after really serving well the VCSQI, Nick, Dr. Tiemann has decided to relocate to Colorado. So that opened up some leadership places to fill in. And I'm very glad to report to you that Dr. Lancy has graciously stepped up to take that role. So as of now, he's the vice chair of the VCSQI, and that will continue till December of 2024. And come January 1, 2025, he will be the chair of the VCSQI. And at that time, Dr. Peter O'Brien will take over the role of the vice chair, so that in 2027, if I'm right in my calculations, he will be the chair for the VCSQI. So that's one thing. Also, I just want you to know that Dr. Tiemann was filling in the role of research and writing committee chair position. So we inquired the interest around, and I'm very happy to report to you that Dr. Provenza from UVA has graciously agreed to step up and take that role. And I'm glad that she did, because all of you know that over 90% of the research efforts for our VCSQI come from the UVA. So it's very appropriate that somebody from there is assisting, supervising, encouraging the residents to take in these activities. Eddie, please remind me about this UVA MPH program.
Absolutely. So this is a project that is under development. Just wanted to put it out there for the group to let you all know what we're thinking, what we're working on, which is a student internship partnership with the UVA School of Public Health, where students could collaborate with VCSQI members for a semester, for a year, potentially to work on different quality and research projects. So the details are still being finalized. We spoke at length with the board about this evening, but we wanted to just get some ideas cranking. If you had potential proposals for the group that you think would benefit from a student and some of their workability, then please feel free to share your ideas with us. We're in the process of getting that program finalized, hopefully for launch, I would say, in the fall. So
very good, Eddie. Thanks for filling me in on that.
To just supercharge some of our VCSQI projects, both on the research and quality side.
Very, very good. I think one of our missions, of course, quality improvement comes to the forefront, but encouraging, preparing the next generation of healthcare team members who would take care of someday us, I guess. So we have vested interest in doing that. Next slide, Eddie. So as promised, I will take a very short time to fill you in. We have some preliminary data about the operating room efficiencies that I have talked about in the last quarter meeting. And then I also promised that I will bring it to the members at large to see what we have learned from that. So we have done some pretty decent preliminary analysis, and our objective is to investigate the impact of operating room times on the post-operative resource utilization and patient outcomes following primary bypass surgery. And our hypothesis is that the longer operating room times are associated with increased post-operative complications and resource utilization. As most of you know, that long cardiopulmonary bypass time, long cross-clamp times have consistently shown to have poor outcomes for the patients. That part, we knew it. My interest was, are there any additional factors from the operating room that will impact the patient's outcome and resource utilization? So that was the impetus for this project. So what we did is we included everybody who's over the age of 18 who underwent primary isolated bypass surgery from January 2011 through December 2023, excluding people who underwent emergent bypass surgeries or off-pump bypass surgeries, or those who came in for a second time around bypass surgery. Also, we noticed that very small handful of outliers were there, those who were above the 99th percentile of our data spread or below the first percentile of the data spread. So we excluded just to make the data more uniform. Next slide. So these are this is how we defined what the timelines are. The number one, the total OR time, which is from entry to the OR and exit to the OR. So that's a very simple one. The second time is total surgery time, that is skin incision to the placement of the bandage in the skin. The third is the non-surgery OR, which is on the front end and the back end of the surgery time, which is time taken for patient to get prepared. Anesthesia time is on the front end of this block. And at the tail end of this block is preparing the patient to leave the operating room. This is where your intensive care unit or the post-operative recovery place resources, like how prepared they are. Sometimes patients have to wait in the operating room for the bed to be available, so on and so forth. So that will impact the later part of this non-surgery OR time. And then the fourth item is surgery time off the cardiopulmonary bypass. This is the time that it takes for the mammary to take down, the vein to be procured, placing the cannulation stitches, so on and so forth. And again, the later part of this time is after the patient is released from the cardiopulmonary bypass machine, you're going through the hemostasis and closing the chest and putting the dressings. And we also, just for the completion's sake, included the cardiopulmonary bypass time also. So this is important to just keep it in mind as to what these time frames are. Next, Eddie. So our outcomes that we focused was primarily morbidities. I wanted to see, what are the morbidities that are associated with different time frames that may be longer than usual. And that includes time to initial extubation, how long do they stay in the intensive care unit, does it impact the total hospital length of stay, and so on and so forth. Next one. Melissa, you might want to mute your phone. Thank you. Yep, she did. So this is the analysis model. We use the logistic regression models for categorical outcomes, such as male, female, linear regression for continuous outcomes, such as cardiopulmonary bypass time, age. The hospitals where the procedures were performed were accounted for as a random effect. And then this is the important part I want to share with you all. We did account for variations in the procedure. Someone may be having 1 vessel bypass versus 5 vessel bypass. So we took into consideration the STS, PROM, and PROMM, which incorporates at least about 20 variables about the patient to make the fields comparable. We also included intraoperative blood transfusions, bypass time, cross-clamp time. Now, this is the important one, teaching institutions. We wanted to just see, what is the impact of teaching institutions? And for this, the definition of the teaching institution I zeroed on is where they have cardiothoracic surgery fellowship trainees. Because in different institutions, there is always some education component going on, whether it's like a nursing students, whether anesthesia residents, medical students. So just to keep what may be the bigger impact of the operating procedure going on. So I said that cardiothoracic surgery. So 2 programs, teaching institutions, UVA and VCU were also assessed separately. Year of surgery, just to account for if there has been any improvements in the procedure of the CABG. Next. So this is our summary table. I just want to spend a little bit of time here explaining what we have learned from analyzing this data. By the way, the total number of patients came to roughly about 40,000. So this is a very large database that we're dealing with here. So I would just first highlight the yellow ones that I have highlighted, which is a 50th percentile. Yep, that's the one. So that's middle of the road as to where our VCSQI family stands. So the second column, the OR time, roughly 5 hours. That's our median time for them. Surgery time, maybe about 4 hours, something like that. And the non-surgery time, roughly about an hour there. And then off bypass surgery time is roughly about 2 hours, 20 minutes or something like that. So that's where we are. But what I am a little bit concerned, or I just wanted to share with you, is there is a pretty big spread between the 75th percentile and 25th percentile. And this is what the best way to analyze the data when the data has not a bell-shaped curve to it. So we could see that, like, there are programs that could finish a bypass surgery in, like, 271 minutes, like, 4 hours or so. And then there are programs that take up to like 6 hours to do the surgery, 350 minutes. So there is a lot of variation is out there. I just want to point out. And then this is after taking into consideration the STS predicted risk of morbidities and things like that. Next paragraph. So this is just like a rough distribution of like how the data was spread. And you could see that like some of them are skewed a little bit to the left. Some are a little bit in the middle, and then some are in the right. So that's the reason that we used percentiles instead of like, percentage and standard deviations. Next one. So this is the important thing. I want you to all really pay attention to it. The impact of total operating room time on first on the top left is the mortality. As you could see that, like, after you go through like about 4.5, 6 hours, it really starts to uptick. So total OR time, irrespective of your bypass time and, operating time and whatnot. And complications that can happen, any complications, which we use like in the index 6 complications that the STS, like, accounts for this one, it has like a pretty linear, steep relationship with the amount of the time that you spend in the operating room with these patients. Similarly, ICU length of stay, steep curve. So the more time that you spend in the operating room, the more time you're going to spend in the intensive care unit. And that also translates to hospital length of stay, which is the right upper corner there. Now, in the lower part, I just like you to pay attention to the lowermost on the right side, which is the total cost. So if I remember, I think our payment for the cabbage on average is about $35,000. And if you could see, if you spend like, a little over five hours after, that time, the cost of the procedure, like overall cost that incurs to the patient, like, that's reported in the VCSQI data, steadily goes up. So there comes a point where actually we may not be financially staying in the black by not being efficient. That's how I see it. So this is for the total OR time. Next slide, Eddie. So this is the total surgery time. So now we have removed the time to prepare the patient, the anesthesia side of the part, and then the time that it takes for the patient to leave the operating room to go to the ICU and such. So how about the total OR time? More or less, it's the same story. So the longer that you have an OR time, the longer surgery times are. And that's another thing that we have looked into the data by like, cutting them into like, 10 percentiles and things like that. There is a very good relationship. It is less likely that you would have a less total surgery time and very long pre and post surgery time. All of these things tend to go hand in hand. So places in our own family here, like of 17 hospitals, there are some places who definitely have put a process in place where everything gets done in a shorter time, before surgery, during surgery, and after surgery. Next slide, Eddie.
Dr. Carter, can I just ask a quick question, clarification? Yeah. So at the bottom where you say total surgery time had no impact on pneumonia, stroke, etc., does that mean the variables above here are significantly associated with surgery time?
That is true. So the only ones that are like, associated significantly with the p-value and whatnot were up on the top, and those who were not were listed on the bottom here. Next one, right? So this is most important thing that I just want our non-surgical colleagues to just pay attention to this one, which is, yes, so surgeon has like, certain way of like, doing fast, slow, whatnot, but this is a non-surgery time. How long does it take for the person to be ready to undergo surgery once they walk into the room? and how long does it take for them to leave the operating room after the surgery is done. Those things also impact the outcome of the patients, perhaps not to the extent that like other the total OR time has done. But if you look at it again, like, the mortality tend to swing much later in the game, but it does go up. It doesn't stay like flat. Same thing with any complication block here. It's not as steep of a curve, but it's definitely like an uptick. It's not a flat thing. It goes the same way for everything, like, cost and such like that. And the things that are not associated with that at the bottom, which is pneumonia, stroke, renal failure, and sepsis. Next one, Eddie. Surgery time minus cardiopulmonary bypass time. This is preparing the conduits, getting ready to go on the heart lung machine. And then once you come off the heart lung machine, time to dry up the patient and, close the chest and so on and so forth. That also factors in. I think the next one is the cardiopulmonary bypass times. So this one we are all familiar with. This should not come as a surprise. This is like a standard data out there. But what all I have presented before this is something that wasn't captured before. Everybody has focused on only cross-clamp time, CBDP time, and they left everything out there. But I just want all the members of VCSQI to know that those other times also matter. Next one. So training versus non-training, we looked at these factors, and what we found out, the only one thing that stood out between the training versus non-training institution is non-surgery OR time, where the p-value was 0.021. So before the skin incision is made and after the dressings are placed, that's when you have some variations in the timing between the teaching and non-teaching institutions. But the duration of the surgery itself hasn't, at least statistically, not significant. What does it mean to us is, I think the surgeons who are supervising the residents or trainees and so on and so forth are keeping track of the time. Whatever the time norm for their institution is, they don't let that thing go out of their norm to let the trainee continue to learn from them. But the trainees are learning while they're catching up with the time frame. So that's what it is. So this is a preliminary data that I just wanted to throw out at you guys. And I requested Eddie to have all of these slides sent to every one of the members of the VCSQI so that they can take a look at it, have some questions, just generate some discussion to say that what does it mean to us? Should we use it to come up with any other metrics to say that how can we get better? Or is this a good step to go forward and say that we were going to learn from programs who are doing things more efficiently than others? So that's what it is. And then I'm working with two residents, Dr. Al Mohib from VCU and Dr. Patel from VCU here. And Al Mohib is from UVA, sorry, and Patel from VCU. And we will be preparing an abstract for STS based on this information once we have more data. And I will open the floor. I'm pretty sure there will be many questions, but I will try to answer them to the best of my abilities. Thank you for listening.
Mohammed, this is Alan. What a pleasure. Thank you very much for this, because there's all these myths that roll around, and you've gone right at them. There's a lot to unpack here, and particularly when it's like any complication, and then but there's no impact on stroke and bleeding, and so how to separate out which complications are really more relevant statistically. That would imply pulmonary or renal insufficiency and not neuro and all. It looked like that the bleeding rates, and I would assume transfusion, increased with lengths of time of the procedures, whether it was the OR, the cardiopulmonary bypass time, or the whole aggregate. And so again, with that being one of the areas that we have focused on over these years, understanding that association a little bit better would be helpful. And finally, I think it would really be incumbent on us to understand better the post bypass time to out of the room, because the surgeon often leaves then, whether they're in the resident training programs or not. And it looks like that's a huge variation, and one that could be a real cost driver. I know the charges are $500 for 15 minutes. So is this an anesthesia thing, a nursing thing, the entire group packing the patient up? If we were able to exclude delays into the ICU, which all of us have more and more problems with this, and that may be skewing some of the numbers with the room turnover times. But thank you again for taking time to sort through this, and what a pleasure it was to listen. And I look forward to going through the slides more slowly so I can assimilate it. But anyway, thank you.
Thank you for your comments, Alan. As always, I value your input into this. Again, this is a preliminary data. Haven't diced the data into the details, but we will continue to do it. My objective here was to just show some basic information for the members and generate a discussion. And to that effect, I'll be quiet and I'll let others speak and ask questions.
Dr. Cotter, this is Judy. Do you think in the slide that we're looking at here with the teaching institutions, is the non-surgery OR time, do they also have an anesthesia fellowship, or do we not know?
We have that is included, Judy. That's a very good question. Invariably at these two institutions, at UVA and VCU, when they have a cardiac surgery, thoracic surgery trainees, they almost always have residency trainees. And there are many programs where they have anesthesia residency trainees, nurse anesthetist trainees, nursing student trainees. So it was very hard for us to say, which one was teaching not. So I only included two where we said that, okay, cardiothoracic surgery fellowship trainees in the surgery doing the case itself. But you're right, they have other trainees in it, and they're in their participation has some impact on the time. Yes.
Thank you.
Yeah. So just have the slides distributed to everybody, Eddie. Just have them take a look. And I welcome, any email or phone calls on this data. I just want everybody to, just think about it and then ask questions as to what could be different, why this one's true, why this one's not true, like Dr. Spear has nicely alluded to. So we need to generate a good understanding and discussion among ourselves, because this is one of the things that I'm passionate about, being efficient. And my next step, if all of you are in agreement, perhaps down the course, is to identify which programs among our families who are efficient, and are they willing to share how they do that. If somebody is able to do 3-vessel bypass surgery in 4 hours versus 6 hours, I will be the first one to learn from them.
Fantastic. Thank you so much, Dr. Cotter, and we will be sure to send out the slides to all of our members.
Mo, this is Jeff Rich. I have a question for you. I'm just thinking about that prolonged cardiopulmonary bypass time that Ellen alluded to. And I'm thinking of a paired measure. If the people who spend more time post bypass, do they have a lower rate of return to the operating room for bleeding? In other words, are they being more meticulous and packing for a while and spending more time doing that? Or Have you thought about, perhaps looking at that?
That's a wonderful question, Dr. H. We have not looked at the rate of return in some of those, shorter OR times, but I will go back and take a look at it. That's a very good question. Yes.
Fantastic. Well, we will look forward to taking the next steps on this project. Looks like Dr. Spear has one more comment in chat.
Oh, just one more
multiple-
thought. I just, the trend now with multiple arterial grafts can skew this a little bit too, particularly the pre-bypass times.
We should be able to look into that one because that data is available at least in the more latest versions, like what grafts were used and such. And Judy can correct me from 2011 on. Judy, you think we'll be able to tease out what is the ratio of arterial versus vein grafts?
It might be longer than that. Absolutely.
Okay.
Thank you. Thank you.
Yep. Wonderful questions, folks. Anybody from the perfusion team has any questions on this one? All right. I don't want to take more time on this one. And Dr. Kontos has kindly put together recent ACC trials that affects our clinical practice, and I will pass on to him. Thank you, everybody, for listening to me.
Thank you so much, Dr. Cotter. So we wanted to recognize Dr. Kontos, who is one of our VCSQI board members, as well as the co-founder of VHAC. He is the medical director of the VCU Coronary Intensive Care Unit, as well as the director of their Chest Pain Evaluation Center. He's also active on a national level with the ACC on their Action Acute MI Registry, the Society of Cardiovascular Patient Care, and the AHA's Mission Lifeline Acute MI Committee. And he served as co-investigator on more than 150 research papers, 100 abstracts, 8 book chapters, and we are just delighted to have Dr. Kontos here with us this evening. So Dr. Kontos, I'm going to stop sharing and allow you to share the slides from your side. Thank you so much for being here with us.
Right. Hopefully everyone can hear me. So thank you all for inviting me to speak tonight. Hopefully, as everyone recognizes, every year there are 3 major cardiology trials: American College of Cardiology, American Heart Association, and European Society of Cardiology meetings. And each of these trials, they present a number of informative articles or studies that help inform our clinical practices and how we're going to manage patients. So the most recent, I thought this was reasonably apropos, is in the beginning of April, the American College of Cardiology met, and there were a number of studies I thought that were interesting. Here's my disclosures. And the 3 that I was going to go into more in depth to discuss are listed below. These include the DEDICATE trial, which is it's kind of a combination surgical and medical interventional trial, which I thought would be useful for given our high proportion of surgical colleagues here. Reduce MI, which explored the use of beta blockers after a myocardial infarction in patients with preserved systolic function. And the 3rd trial, which is probably of greatest interest to at least interventional cardiologists and many of us that deal in this field, the DanGer Shock trial, which looked at microaxial flow pumps, better known as Impellas, in patients with cardiogenic shock after STEMI. There obviously were a large number of other trials presented, and 3 of them here that I won't go into great depth, but just to kind of give you a little bit of taste of some of these information that was available. One was the Ultimate DAP trial. This explored a strategy that's been increasingly used in which, rather than aiming for 12 months of dual antiplatelet therapy in patients undergoing stenting, instead down titrating the therapy and dropping off aspirin at various intervals. In this trial, and these studies have been done in a number of different cohorts, initially in patients with stable coronary disease, then moving over to patients with ACS and shortening the intervals. And this is one of the shortest one, which looked at just 1 month of ticagrelor, looked at 1 month of dual antiplatelet therapy, and then subsequently in those who did not have either ischemic or bleeding complications, dropping off the aspirin and continuing on afterwards. And similar to what other trials have found, primarily in non-ACS patients, that using single antiplatelet agent with ticagrelor alone, these substantially decreased major bleeding without any increase in ischemic events overall. And I think what we're going to see, just given the large number of these trials that have come out, that in updated guidelines, this will now be one of the more preferred strategies to use. Analogous to this, the European Society of Cardiology recommendations have actually provided recommendations to dropping off aspirin earlier in patients that are at risk for bleeding, either at 3 months or even as short as 1 month, and those that have a high bleeding risk. So I think we'll see the American guidelines adapt this probably in the next couple of years when the new guidelines come out. The second trial was the IMPACT MI trial. It was using empagliflozin, an SGLT2 inhibitor, after MI in patients that were at risk for heart failure. They either had to have symptoms of heart failure or reduced systolic function. Multiple studies have been performed using a variety of different SGLT2 inhibitors, primarily in heart failure patients with, and importantly, without diabetes, and have found significant reductions in events. This tried to expand this to a potential heart failure population after MI. However, they did not find a significant reduction in what they used as their key endpoint, the risk of time to first heart failure hospitalization or mortality. In the secondary analysis, they did find that there was a benefit of empagliflozin, with a significant 23% reduction in the relative risk of the first heart failure hospitalization and an overall 1/3 reduction in risk in the risk of total heart failure hospitalizations. So I think that, again, this is expanding to a population that's higher risk, and we may see increased use of these type of medications. The third trial was a kind of an innovative one. It was using an experimental agent called CSL112. This is done to reduce apolipoprotein A1 in patients after acute MI. It was somewhat of a, I think, maybe of a reach in this trial, in that they looked at an appropriate population, patients with acute MI who were an enriched population. They had to have multivessel disease and additional risk factors. But they were looking at overall event rates in a very early period of time, at only 90 days, looking at the combination of cardiovascular death, MI, or stroke. In this trial, patients were randomized to a placebo or treatment with this agent, with 4 weekly infusions of this agent. And unfortunately, there was no significant reduction in death or MI in this population. However, this was an all-comers trial when they actually focused on those who had an LDL greater than 100, people that you would think would be of greatest benefit for treatment with a lipid-lowering agent, did find a significant overall benefit in that cohort. So the first trial I'll discuss a little bit more in depth is the DEDICATE DZHHK or 6 trial. As with all trials, they have to have some an acronym. I not quite figured out what the last initials were. I think maybe it's primarily because it was a German study. This was looking at transcatheter aortic valve implantation, or we would call it, Europeans call it TAVI, in the United States we call it TAVR, versus surgical valve replacement in those who are at low to intermediate risk. As background, we have a substantial number of studies that have demonstrated the benefit of TAVI or TAVR in patients with severe aortic stenosis compared to surgical valve replacement, initially starting in patients who were not candidates for surgery to those who were considered high risk, and expanding down to lower risk populations. Overall, a meta-analysis of 4 trials that looked primarily at just lower risk patients found no significant in mortality extending out to a time interval beyond 4 years, or the rates of stroke in these populations and those who were considered low risk. Although if one looks at the overall hazard ratio, the early risk of stroke was substantially reduced in those undergoing TAVR compared to those undergoing surgical replacement, with somewhat of a catch-up after that period. However, these studies are primarily limited by those restricting patients to a specific device for that trial, primarily because all of these trials were industry-sponsored. To address these concerns, this organization performed a multi-center study that actually looked at patients coming in for considered low to intermediate risk who had symptomatic severe aortic stenosis, who were eligible for both procedures, and underwent a heart team assessment to determine the appropriateness for the overall therapies. Exclusion criteria for those that we see in most of these trials could not have a congenital aortic valve. It could not be a cardiac reoperation, no recent revascularization, no concomitant valvular disease or significant LV dysfunction, no recent stroke, and having a contraindication to a single isolated valve procedure. So these were what was considered some typical patients undergoing a single valve procedure. Characteristics are here. They show overall average age was about 74 to 75 in both groups. In contrast to other studies, the rates of female gender, which were in the 40%, kind of the inverse of the male sex, was actually higher than seen in a number of other trials. So showing expanding this procedure across genders. Patients were considered low risk as seen below. They were all symptomatic with normal ejection fractions, with about 1/3 of them having concomitant coronary disease. Overall, the primary outcome seen at 1 year was significantly reduced in those patients undergoing TAVI, with a significant, almost 50% reduction in the rates of death or stroke within 1 year, 10% down to 5.4%. We look at secondary outcomes, separating out death and stroke alone, again showed similar overall outcomes with a significant benefit of TAVI compared to surgical valve replacement for both mortality as well as overall stroke rates. Secondary outcomes are shown here. All of them tended to be higher in those patients undergoing surgical valve replacement, except for those that you might expect. Vascular access complications were significantly higher than those undergoing percutaneous valve replacement, as well was new permanent pacemaker implantation, almost double the risk in those undergoing TAVI, something that's seen in the majority of trials and is a limitation to expanded use into younger patient populations. Overall, the authors concluded that among patients with severe AS at low to intermediate risk, surgical risk, TAVI with prosthesis selection based on operator discretion was not inferior to surgical valve replacement for death or stroke at 1 year. For all these trials, they have certain caveats and limitations for this trial. This was limited to 1 year follow-up, although they are planning on extending it out to 5 years. Similar to other TAVI trials that excluded patients with bicuspid aortic stenosis, concomitant coronary disease, or valve disease. And because this was performed primarily in the time period around COVID, overall outcomes potentially could have been impacted by this. Clearly, we need data on long-term outcomes. Most of it has been fairly promising, but again, looking at this patient population, an age of 75, getting 10-year outcomes can be difficult to do, but I think it's going to be critical for how we're going to expand and think about using percutaneous valve replacements in patients that are getting increasingly younger and are knowledgeable about this procedure and may not want to undergo may not want to undergo a surgical procedure as compared to a percutaneous procedure. I'll pause here for any questions people might have about this particular trial or comments. And we'll have some time at the end for comments for any of the 3 different studies. I'll show it. The second trial I found was interesting. It's called the Reduce AMI trial. It was the use of beta blockers after MI who had preserved systolic function. Some background is important, I think. Many of the studies that demonstrated the benefit of beta blockers were performed in the pre-reperfusion era. These patients often had large infarctions, often presented with LV systolic function after it, and it predated much of the contemporary therapy we have, including such as early revascularization with PCI, potent antithrombotic and antiplatelet agents, rare use of high-intensity statins, and the use of angiotensin blockade with either ACEs or ARBs. So in an updated meta-analysis performed about 10 years ago, they found that if you looked at trials performed in the pre-reperfusion area versus those afterwards, those performed afterwards did not demonstrate a significant mortality benefit, although there was a reduction in MI and a risk of angina. Although even in that, those clinical outcomes were only pertinent for the first 30 days. So what these authors chose to do was to reinvestigate the role of beta blockers in the population in which has not been demonstrated beta blockers and have not been shown to demonstrate a benefit. Those who have preserved ejection fraction. It's somewhat counterintuitive, but it's clear from all the data we have that the benefit of beta blockers is inversely proportional to ejection fraction. The lower the EF, the better off you are. And the cut point is somewhere in the 40 to 50% range in which the benefit of beta blockers drops off substantially. So these authors included patients with type 1 MI who presented within 1 to 7 days after acute MI and had coronary angiography that did demonstrate obstructive coronary disease. So we're looking at people that truly had coronary disease and truly had an infarction. And they had to have, as this you might recognize from the study, had to have a normal ejection fraction. The way this study was performed, with almost the vast majority of patients were enrolled in Sweden, with a few in Denmark, to enhance enrollment and also to save time and money. This was performed in the background of a large registry that is performed in Sweden, in which all patients with acute MI were enrolled in this registry. So this allowed simplified data collection because all the data is already being performed as part of the registry. Unfortunately, as part of that, simplicity does add some complications, and this was not a placebo-controlled trial. They did use 2 types of beta blockers, metoprolol and bisoprolol, with about 2/3 receiving metoprolol. And those who did present with beta blockers on a beta blocker therapy at the time of MI, about 10% of the population included in the trial were actually weaned off over approximately a 2-week period and then continued on with their randomization therapy. Overall, the primary endpoint was a combination of death or non-fatal MI with secondary endpoints breaking these MACE events out separately: death, cardiovascular death, MI, heart failure, and atrial fibrillation. Demographics, patient age was similar to what we see in the US, a median age of about 65, with about 1 in 5 being female. Risk factors are demonstrated here, with about 1 in 5 smoking, a little less than half having hypertension, and about 1 in 6 having diabetes. This was a lower risk population, with few of them having known coronary disease, as can be seen here. And overall presenting characteristics outlined down here that were important, I think. About 1/3 of them presented with ST elevation MI, and again, about a little over 10% of patients were actually on beta blockers at the time of presentation. Vast majority of these patients underwent revascularization, with PCI being through the preferred mechanism in about 96% of the patients. And I think importantly, when we look at this population and how to put it in context, these patients were treated quite well, with almost all of them receiving goal-directed medical therapy, including aspirin, P2Y inhibitor, ACE or ARB in over 80%, almost 80% of the patients, and almost all the patients receiving statins. So almost all the patients received the recommended therapies that we have currently. Overall, there was absolutely no benefit of beta blockers with a hazard ratio of 0.96. Importantly, they had actually estimated the event rate would be approximately 7% per year. In contrast, it was only about a 2.5% event rate per year. So overall, quite low, and as might be expected in this population with primarily single vessel disease undergoing PCI and on many of the guideline recommended therapies. This is a breakdown of all the endpoints. And again, almost all of them line up right around 1 with no hint of benefit across any of these particular endpoints. Importantly, the risk of admission to hospital because of heart failure was actually very low, under 1% in both the groups. And one of the potential limitations is crossover that you see in any trial. In this trial, about 82% of the patients with beta blocker group were actually taking them at 12 months. So about 1 in 5 had dropped it. And about 1 in 6 of those who were in the placebo group were actually on beta blockers as well, perhaps abrogating some of the differences between the two groups. Subgroup analysis all kind of lined up right around the identity line with no obvious favorable benefit in any particular group overall. The authors concluded that in patients with acute MI with preserved LVEF, long-term treatment with beta blockers did not reduce the risk of death or MI. And some of the caveats and limitations, as I noted before, there was a drop-off in the group of patients who were taking beta blockers and a drop-in in those who were randomized to the placebo group. They only assessed beta blocker use at 1 year, and this trial did go on for almost 5 years, so there's a potential that these differences actually came closer together, making it more difficult to actually assess for differences. As I noted, it was not a placebo-controlled trial. They did not provide any information on ventricular arrhythmias or sudden death, in which we know beta blockers can be quite beneficial. However, given the normal ejection fraction, the overall low event rate, it's unlikely this would have affected the outcomes. Because the event rate was so low, if you look at the actual confidence intervals, it does extend from a potential 21% benefit with beta blockers down to a 16% harm. So there is a chance that this trial was just underpowered to demonstrate overall benefit. And as some have noted, the quote, evidence of absence is not the same thing as absence of evidence. However, again, the event rate was very low. There was no signal of benefit in any of the secondary outcomes or in the second subgroups. And even if there was a benefit, the likelihood of being able to demonstrate it would be very difficult given the low event rate. So I think this is one of the first large trial to inform us that something that many of us have suspected and had been demonstrated in observational trials, that beta blockers may have limited utility for reducing ischemic events after acute MI, so long as ejection fraction is preserved. This is not the only trial that's out there. There are at least 3 ongoing trials that are hopefully going to come out in the next year or two. And I think once we have information on those, particularly if they align with the reduced MI trial, be another trial that will affect overall guidelines, and the use of beta blockers, at least on a routine basis, will not be what's likely, I predict, is not going to be indicated in the next 2 to 3 years. Any questions or comments?
Mike, that's quite a comprehensive review of like everything that has happened in the last year plus. So how practical are these things regarding, taking somebody off the beta blockers who are already on it for some of those reasons? I mean, would you recommend that we should go around like, taking them off if they're on now?
That's a great question. I think that's going to be something that may happen. There are, I think there was one recent trial that actually looked at that randomized patients 1 year after MI to stopping the beta blocker and found that there was no risk of harm in those patients. So I think that's something that potentially will occur. It does have the one issue is if they are on it trying to figure out what to do with their blood pressure at that point may be an issue. So it may be a little more complicated. I think what these trials are informing me is that although I continue to use beta blockers after MI, my threshold for changing it off has dropped off substantially. It's in that if they're having any kind of side effects, I don't really push it. If they're not having angina, if they've had complete revascularization, just because of the lack of overall benefit. And as far as dropping off the therapy, it's going to be interesting. I think it's somewhat analogous to what we're seeing with atrial fibrillation, in which aspirin is no longer recommended after the first year. And getting rid of it at that point is something we've started to do, or even for primary prevention for coronary disease, in which many of these patients are on aspirin. But a few years ago, the updated guidelines say, particularly in those older than 60, dropping it off would be important because of the risk of bleeding.
Very, very interesting, because I'm pretty sure many of us who look after some of these patients, fatigue is one of the most common things that patients relate precisely to starting the time on beta blockers. So that would be one good group to just choose and at least, like, try to get the thing off their list.
I think that's a great point. I've seen, I've had that same issue with a number of my patients, and I've noticed particularly in those that present with smaller ventricles, they may end up having chronotropic incompetence, and getting rid of the beta blocker can make them feel better. The third and final trial I'll present is probably one of the more interesting ones and difficult, probably the most difficult trial to perform. It was looking at percutaneous transvalvular microaxillary flow pump, or simply placing an Impella in patients with infarct-related cardiogenic shock, the DanGer shock trial that was also presented. The authors hypothesized that routine use of this pump on top of standard guideline care in patients with STEMI and cardiogenic shock would result in lower mortality compared to standard therapy. For just as a quick background, the Impella is placed, at least in this particular device, the CP is placed femorally. It goes up through the aorta, across the aortic valve into the left ventricle. It sucks blood from the left ventricle and it squirts it out in the aorta, and can provide an additional cardiac output somewhere in the range of 3 to 4 liters, depending on the individual patient. As background, I probably should have flipped those two studies. Cardiogenic shock is one of the feared complications we have in those patients presenting with STEMI. It occurs in a small minority, but it can be quite devastating, as the mortality can exceed 50% in some cohorts. The only thing that's demonstrated benefit in these patients has been revascularization, and that was in the shock trial well over 10 years ago. As you might imagine, people explored using mechanical support in these patients across multiple different devices. Unfortunately, they've not demonstrated any improvement in outcomes. There have been 2 randomized trials using balloon pumps with no benefit. ECMO was actually performed a little bit dated. 1 large randomized trial with a total of 4 clinical trials with no benefit. Even looking at Impella devices in 3 randomized small trials also did not show a benefit, with registry studies consistently showing an excess of bleeding in these patients. One of the limitations of these trials, particularly the ECMO and Impella trials, is the data is likely skewed by the high numbers of patients presenting with cardiac arrest, which in some trials has been as close to 80% of the patients. And it's difficult to show an improved outcome when you can expect well over half your patients to die of a non-cardiac cause. In fact, in one of these smaller Impella randomized trials came out, I thought the editorial was very informative when it said that no, the answer to this is not to stop using the device and not do any more studies. The answer is to actually do clinical trials and exclude all the patients that were included in this trial, because it's a very limited, particularly those with cardiac arrest, you're very unlikely to show a benefit in those trials. So these authors actually took that to heart and began this trial, and it's one of the more difficult trials to do. And in fact, it took over 10 years to complete the data collection. They looked at patients who came in with STEMI, and they looked at a very defined cohort of patients, those with STEMI presenting within 36 hours who had shock for a short period of time with reduced systolic function. It looks like a very small number of patients randomized, only 360 out of the over 1,200 evaluated. But it's important to keep in mind that many of the reasons patients were excluded were those that were appropriately excluded that would not be appropriate for using such a device. This included about half, a little bit over half the patients excluded who had cardiac arrest, those who had other non-cardiac causes of shock, and a significant small minority of patients who either had mechanical complications in 5%, and 8% who had such poor vessel access they could not undergo device placement. So I think the exclusions are appropriate. It does give pause when we look at patients who do come in with cardiogenic shock, that the small numbers of patients who actually may be eligible for this device. Characteristics are shown here. Mean age was similar to most general populations, 67 and 69, versus with the majority of patients being male at almost 80%, with a number of concomitant risk factors. Median blood pressure systolic was 84, as you might expect in a shock population. Mean lactate was over 4, approximately 4.5 across both cohorts, with significant reduced LVEF, about 25%. Only about 20% underwent resuscitation before randomization. Again, they had to be awake and alert to be undergoing randomized, so they were not comatose patients. And as we see in most shock populations with STEMI, almost 3/4 of them had acute myocardial infarction, with most of these patients being in SCI stage C, which means they required vasopressors, at least 2 vasopressors to control, or mechanical device for hemodynamic support. Stage D, in which they continue to deteriorate, in stage E, which is the worst classification for cardiogenic shock. Just to give an illustration, again, almost 3/4 of these patients were intubated. Vasopressors was, again, might expect, were used in the vast majority of patients, as were inotropes, in about 69% versus 62%. One of the difficulties in any of these trials that we saw with both medications, but also with devices, is the overall crossover rate. And in this trial, it was approximately about, the number down here, about 16% of those undergoing Impella placement had to have escalation, primarily to ECMO, with about 21% in the standard care arm also requiring escalation. So that would tend to drive the differences towards the null, because of the number of patients in the standard care arm actually receiving mechanical support. One of the questions I had when I looked at this was how many patients ended up with LVAD or transplant, and it was actually quite low. About 6% had LVAD in the Impella arm and 2% in the standard care arm. Transplantation was actually used in probably approximately 1 patient, I think, when I looked at the subgroup analysis. And again, just to kind of outline the key, I think, key things of how these patients were treated with vasopressors, inotropes, and need for escalation to additional circulatory support. Most of the patients underwent revascularization, well over 98%. Door to balloon time was actually fairly short, despite being in cardiogenic shock, running under 1 hour. The interesting part was the mechanical support. The median duration of Impella support was about 2.5 days, 59 hours. And when we in those who did undergo Impella support. They found a substantial reduction in improvement in outcomes with Impella, with mortality dropping from 58.5% down to 45.8%. This was an absolute 13% reduction, a relative 25% reduction, and resulted in a number needed to treat to prevent 1 death of 8 patients needed to treat to prevent 1 death. So a substantial overall benefit with using this device. Use of Impella did not come without a cost, with some significant numbers of overall complications. Moderate to severe bleeding was almost doubled in those undergoing Impella support. And as you might expect, limb ischemia was substantially higher. Almost 1/2 of patients undergoing mechanical support required some type of renal replacement therapy, with about a little bit over 1 in 10 developing overall sepsis. Length of stay is shown over here. It was about 6 days for the Impella group versus 3 for standard care, with a hospital length of stay about double at 12 days versus 7. At 30 days, about 12% of the Impella group were still in ICU, and 23% were still in the hospital, compared to lower rates of the standard care arms. One of the things, just to go back here to look at the overall event rate, one of the interesting things about this was if one were to look at the 30-day event rate here, the overall differences is not quite as much. The curves continue to separate out to about out to 180 days, with mortality leveling off and those treated with mechanical support, with the standard care arm continue to increase over time. There was some thought, at least one of the commentaries mentioned, that the reason for shorter lengths of stay is that these or less complication rate in those treated with standard care may have related to the fact that they died faster. Although I don't think that's entirely true, because if we look at the overall event rates, the curves really didn't start to separate out till about 3 to 4 days, and to about 10 to 15 days. And I find this one of the more interesting things about the trials. We always think that people who have cardiogenic shock, they either die very quickly or they get better very quickly. This would be a sharp contradistinction in that. And I think the rates of complications indicate that these patients often undergo kind of a stormy course, but at the benefit of living longer. Overall, the number needed to harm was 6 patients. Subgroup analysis here showed some interesting things in that female gender had no overall benefit. It's unclear if this relates to just the smaller numbers of patients who were enrolled or some other different treatment characteristics. Those who had lower blood pressure, presented with a mean arterial pressure less than 63, also had a greater overall benefit with mechanical support with Impella. And it makes one think that you can perhaps identify a cohort of patients who are either too sick to benefit or those who are too well to benefit. And trying to sort that out, I think, is going to be an important time period, important element to sort out. The other interesting thing I thought was important that they included was years of randomization. Again, this trial was performed over a 10-year period, but there did not appear to be a significant difference in overall outcomes versus those enrolled in the first 5 years compared to the last 5 years. Now, the authors included that routine use of Impella in addition to standard care reduced death from any cause in patients with STEMI and cardiogenic shock, although it was associated with a significant increased risk of adverse events. And I think it's important to recognize that the results of this study can't be extrapolated to other causes of cardiogenic shock, particularly cardiac arrest, perhaps non-STEMI, and then non-ischemic cardiogenic shock. Obviously, again, this trial has some caveats and limitations. It doesn't really inform on shock patients with other types of conditions. Although, again, I think trials in patients with high rates of out-of-hospital cardiac arrest have not shown any benefit. The time period was long, again, although they showed no difference in mortality of that time period. Importantly, this was performed in a small number of select centers that have a skill level to manage these devices. The high rate of complications, again, we've highlighted. And then I think another interesting factor that is being studied in a clinical trial is that those who were randomized prior to PCI, the vast majority of them actually underwent Impella placement prior to revascularization. This is in contradistinction of what we've always been taught. Getting the artery open is the most important thing. And it may be that the time period that it takes to get the artery open, which may be as long as 30 minutes, shortest 20 to 30 minutes, but long as 60 in complicated cases, may be adding a substantial increased risk, and providing hemodynamic support prior to revascularization may reduce what is often been termed kind of this cascade of events where we go from cardiogenic shock to multi-organ shock. And this is actually being studied in a randomized trial as well to determine if this is the appropriate strategy. So again, an important trial, I think, because it, as some interventionalists said, it makes one feel good that what we've been doing for the last 5 to 10 years actually has now been shown to be overall beneficial. And I think this perhaps it's going to change care. This is the first thing that's really demonstrated improvement in outcome in shock patients since the original shock trial that was performed about 10 to 15 years ago. Okay. I'd be glad to take any questions about this study or any other of the trials that I brought up. And I'll give it back to you, Eddie.
I think the impeller support was done in a timely fashion, though. That's one of the things that comes to mind. Is it too little, too late? Was there a measure to see that how soon they were implanted?
Yeah, I think that's a great question that they did. Median time, I don't know if let's see. Median time from randomization to play. I don't think I included that here, but it was fairly quick. And again, I think to your point, it's a great one. One of the things they did do in this trial was to make sure they included patients that had early shock, they didn't wait too long. And I think that's where you many places run into this issue that we've gone from a scenario of cardiogenic shock to multi-organ shock. And once that happens, particularly in the older patient, I think the cat may be out of the bag in those patients. It may be even more beneficial to do it even earlier to help prevent those patients who subsequently develop renal failure, which was seen in such a large cohort. But I think earlier intervention is, as you noted, is probably the key to this particular trial.
Mike, that was a great review, especially danger shock. It's just been a very interesting and impactful trial, I think. Is there any, kind of putting your registry hat on, is there any look at or exclusion for the kind of, I guess the unload trial or something, as you mentioned, is coming out, placing the Impella before you perform primary PCI? Is there any look to say that's an exclusion or that won't negatively impact door-to-balloon times the way they do, say, for other events, arrests, cardiac arrest, and things like that? I'm wondering if in this age of rapid reperfusion, and we've got to get our times, we've got to get that artery open. If there's a look by NCDR or other organizations to say no. If you felt like an Impella needed to be placed pre primary PCI, then that's okay.
I think that's an excellent point. I think a lot of interventionalists, and I know we've often tried to drive revascularization as quickly as possible, again, with the thought that getting the artery open is probably the most important thing you can do to improve outcomes. And this trial, I think, helps to provide a little more information along with the kind of more observational studies that early Impella use in those patients are going to get it. That may be particularly beneficial. And I think that may be particularly true for the anterior MI. I think with the inferiors, a lot of times once you get it open, things get better fairly quickly. But with the anteriors, we've all seen that although the artery's open, the flow is still can be particularly crappy. From the registry perspective, they do have an out for almost all of these things. If you think that mechanical support is needed or something else that results in delay to treatment, it's simply documenting that in the chart that this is the rationale why there was a delay to intervention, that the patient was unstable and required hemodynamic support prior to performing the procedure. So I don't think that would be a limitation for people to do that, so long as they've provided the appropriate documentation. If there are any other questions, if not, I'll turn it back over to you, Eddie and Sherri.
Fantastic. Thank you so much, Dr. Kontos. Really appreciate you. So in our remaining 19 minutes here, we're going to go through a quick review of our quality data from the VCSQI database. Here's a quick summary of the 4 registries that we're currently working with. At this point, we have over 200,000 operations in both the STS and ACC worlds. And as Dr. Cotter had mentioned earlier, that there's a pretty active research wing. As Sherri mentioned, all the quality initiatives help key off of these data from these registries. So here is a quick look at some of our quarterly report data, as well as a couple other special looks at our database. So first I wanted to start with our newest registry, which is the STS ACC TVT database. We are up to 9 centers across Virginia who are submitting data to VCSQI from this. This is of, I believe, 13 TAVR centers across the state. So we are about 2/3 of the way there, and hopefully more can join in soon. This is what we have thus far. You'll see your hospital code de-identified on the bottom of the screen.
Just going down to check on the guy in the unit, and then how.
Our first measure here is average length of stay. This is for all TAVR procedures from the last 3 years, which is about 4,600 in our database. This is all comers, so any TAVR that we have broken down into pre-procedure and post-procedure length of stay in blue and orange, respectively. These are compared against the VCSQI and national TVT medians, respectively. So we see here there is a good amount of variation. Lowest centers are around 1.8 to 2 days total. The highest centers are closer to 3.5, almost 4. And they're even within pre and post procedure length of stay. Some folks are keeping them a little bit longer pre-procedure, so we can see some of that variation based on the color breakdowns. Feel free to jump in with any questions, comments, by the way.
Eddie, what
Yes, sir.
quality metrics we have expanded or included in the last couple of years to the standard, metrics that we used to follow before?
As far as TAVR is concerned, or just in general?
Just in general, so that we can start to keep, more focused look on those things.
That is a great question, Dr. Cotter. At this point, the TAVR is all pretty new to us. We've just been reporting on this for the last 6 to 9 months. So most of those are new. As far as cath PCI goes, we started to recently track a couple of things about radiation usage. And I think stroke is another new measure, which we'll see in some of the later slides. In the STS world, we have started to track the multiple arterial graft measure, and failure to rescue is another new piece that you can look for on our quarterly reports.
Very good. So I think this is important for our members to know that when you do receive the quarterly reports, please also pay attention to some of the new additions that are being added, because we're not used to seeing them before. So it may require a little bit of time to spend to understand what is supposed to be, acceptable, what is better, what is something that needs improvement, so on and so forth. So thank you for including all those things, Eddie. And I have to say that each time that we add any of these quality metrics, it adds hours and hours of time for Eddie and Sherri to go behind bringing the information to us on the desktop. So just want to take a moment to recognize them and thank them for what they're doing.
Thank you, Dr. Cotter. And likewise, I would like to thank all of our members for sharing all of your ideas for what you want to track in terms of the data. I'll give a special shout out to our Bon Secours team members whose cardiology data we are now tracking. And they also suggested a number of new measures from cath-PCI, which we were able to include in our latest set of reports. So please share any ideas you have. We have really the raw registry level information, so we can drill into any particular subpopulation, any measure you can think of. As long as we track it in the database, we can show it up here as part of our quarterly data. Couple other measures from our TVT database. Here is the composite vascular complications measure. I wanted to show this just because there was a wide variation between centers, also a discrepancy between the VCSQI and the TVT averages.
Yeah, as I said again, Eddie, this information is relatively new to us. It's going to take a little bit of a time to understand them carefully and perhaps make some sense out of it to say that okay, you know, this is what we should be doing or should not be doing.
Absolutely. And if centers are interested in patient level breakdowns, for instance, we can provide those as far as which patients incurred different post-op events as well, if you'd like to see that.
And then Eddie, one question would be for these type of data, particularly vascular complications and outcomes, is separating out those. Forget that point. But it would be helpful to know: are there large volume and low volume institutions, and is there some variability related to that? I think as Eve just noted in the chat, same point.
Great point. We have a pretty wide variation in terms of volumes. There are a couple centers that are, I would say, low volume in more about the 50 to 100 procedure per year range. And we do have some high volume centers that are, you know, in upwards of 200 cases a year. So there's a pretty wide variation.
And maybe the other way, if you're going to divide that out, would be volume by operator. Just because if it's one thing to have a center that does 75 and it's one operator versus one that does 100 and it's, you know, say 5 operators.
That would be really interesting. We can sort of like we show on the cath-PCI data or STS data, we can show volume demarcations, and that would be a different one, volume per operator. Thanks for sharing, Dr. Kontos. Our last TVT measure is one that's familiar in terms of both the cath-PCI and STS worlds. I thought it'd be interesting to look at stage 1 AKI, which is by the rifle criteria, either a 0.3 milligram per deciliter increase in serum creatinine or 50% increase or new requirement for dialysis. And here we see rates that are a little bit higher than what we see for PCI procedures, which are between 7 and 8%, but lower than CABG, which can be in the 20% range. This could possibly be something for our AKI subgroup to look at too. couple of charts from CAP-PCI where I'm just hitting some highlights here. The more detailed data is available in the quarterly reports. So let's keep on AKI. Here is our observed AKI rate across all PCI procedures in VCSQI for the last 7 years. This is data complete through Q4 of 2023, by the way. See a little bit of variation, but generally in that 7 to 8% range. Pretty steady. A little bit of a dip in the past year. This next one might look a little busy for folks who haven't seen our standard quarterly reports before. I'll just give a brief overview of how these graphs are structured, where they're broken out by low, medium, and high volume centers. The bar clusters show the previous 2 rolling 4-quarter periods, in this case, the 2 calendar years of 22 and 23. And they are sorted by performance within each volume grouping. So the blue bars will step up like a little staircase. Along the bottom again are the hospital codes, and we will see a plus sign if a center is a positive deviant and an asterisk if they're a negative deviant as compared with the rest of the VCSQI average. So for this measure on AKI, it looks like our centers are performing on average similar to the ACC average, maybe a hair below, but still a good amount of variation between sites and a couple top practices that have earned that plus sign distinction. So we'll keep tracking this one, especially as our AKI team released recommendations both for treatment of cath and PCI patients, and as well as those going on to open heart. Here's a new one of the new areas that Dr. Cotter mentioned, which is average cumulative air kerma. This one was fascinating because there was an extraordinary amount of variation between centers, almost 3 to 4 times the rate of the lowest site at the highest centers here. That's rare to see in our database in terms of that amount of variation.
This is for the PCI, right, Eddie?
Yes.
Yeah.
And this is all PCIs.
All PCIs, yeah. So again, these are the things that make us to think, well, what is it that, some people are doing better than us? And the inquisitiveness should be there to get better and to serve our patients better.
I think the other way to try to sort this out too is to come up with some sort of standard procedure. So for example, single vessel PCI versus complex PCI, because obviously if you're doing multi-vessel CTOs, those kind of things, those are going to require much greater overall radiation doses, and that may be some of the variability. Yeah, as cardiologists and probably surgeons too, anytime we see variation, we try to find reasons to account for that variation. That doesn't make it our fault, that it's how the data was analyzed. That's the problem. So I think that would be a potential explanation for some of these.
We have such a good sample volume here with nearly 12,000 PCIs per year across our sample. So we can definitely look at subgroups like that and still not sacrifice statistical power.
And one other way to look at this too is if you have, when you plot it out, the NCDR average or medians, include that as well, because that will kind of be what the national average is for comparison.
That's a good point. Like we have standardized outcomes for our STS data, if we could just put like one of those bars from the NCDR, that would be helpful too. I agree with Dr. Kontos' point that maybe some differences could be accounted for complexity of the procedure being done. But since we have a large number, as Eddie had said, it will definitely be of help to see if we just, put the data out by one vessel versus two vessel versus three vessel. So that would give us a chance to see that, okay, is there a room to improve here?
Noted. We will definitely take a look at that. Our last CathPCI measure here, this, Dr. Cotter, relates a little bit to your efficiency presentation on the STS side. I just decided to take a quick look at average procedure time within CathPCI. Again, we can definitely break this out for single versus multi-vessels or other subgroups. But at a high level, here is the variation in procedure times between center.
This data seems to be a little bit less heterogeneous compared to the previous one.
I don't know if we have some of the, like you broke it up by CBB or non-operative CBB time, things like that. I don't think we have the ability to splice this out in too much more detail, but we could definitely take a look at that too. Oh, here's one more actually from CathPCI, which we've been tracking. Same day discharge for our elective PCI population, which we see a wide variation between centers as well, with some above 80% and others hovering around the 20% mark.
Eddie, this measure, go ahead, sorry.
No, I'll let you go ahead, please.
Yeah, thank you. Eddie, this measure's garnering a lot of interest. I think across the state, we've just kind of heard it bubbling up, but can we share protocols?
That would be fantastic. I think we've received a couple from centers in the past, but more would be most welcome.
And do you just put those on the website?
If you want to email them to me, we're working on strategizing or changing the way that we share protocols. Oftentimes our members want to know which number is that protocol aligned to. So that's something we're working on and we will discuss further with the board as far as sharing. In the past, our members have told us to share it. And so if the Centra shared a protocol, we share it as Centra's.
Sherri, I think you had tried, I forget which protocol, to pull protocols together as kind of a library.
Mm-hmm.
We can talk about this at the board level, I think that'd be very helpful, because I think all of our centers have one or two areas where we'd say, boy, I'd like to I need to write this protocol for my center and I need a quick reference. I need to see what other organizations are doing.
Sounds good.
So what we did in the past, more recently, acute renal failure prevention protocol, we gathered 2 or 3 protocols from the centers who have the lowest amount of AKI post, procedure, whatever the procedure they were doing in. And then we had a small group of people, I think the Mike Brown has spearheaded the last one. They kind of merge those 2 or 3 of them together. Then it becomes like one of our VCSQI protocol for AKI prevention. So we could do similarly for this one, Mike. We could request protocols from the centers who are 80% discharges post PCI, and then we can put together that and weave in and come up with like one document that will be posted on the VCSQI website for everybody to share.
That sounds great.
And that gets around the potential problems patients, people might have with sharing protocols all across everywhere. And then someone saying, oh, this is what they use. This is what they use. It has to be good. I mean, that's not the right way to put it, but by taking best practices and combining 2 or 3 or 4 protocols, I think that's a great way to do it.
I would also, if we do it that way and there are variations, we probably ought to run those protocols and just make sure that the benefits are sustained. You presume they are, but if we're modifying the protocols, then we ought to just continue to monitor and check.
Good point. Again, we have done that as recently as, I don't know if Mike is on, Mike Brown is on here. He spearheaded one very good protocol for the AKI prevention. So we could certainly do this for the same day discharge. That would be a wonderful protocol to have.
This is Alan Spear. The one caveat I would give to this is that in the last 2 years, we have done a really poor job in trying to keep up the sustainability of our protocols. I mean, we were fastidious around the transfusion and amiodarone, early extubation, AKI. And with our turnover rate, with our nursing staff and APPs, foolish me, I kept thinking that these were translatable. They're not. And so the only plea is it's not the protocols in and of themselves, it's the ability to maintain them and to constantly re-educate your staff.
Alan, I think that's a great point. It's institutional memory is so critical, and you don't realize how much it is until you get that staff turnover. We had that at our institution for a lot of our chest pain protocols. And for someone who's been an institutionalist like I am, I'm kind of going, why are people not doing what we were doing? It's worked really well. And I think it's because it was 3 levels of turnover since we started that.
I completely share your concern on that one, but having, at least like one reference document somewhere that the new person who's coming up on to fill in the job can have a starting point. So that's where these documents will come in handy, just to have it as a reference to get started with.
Mo, you're exactly right. That wasn't at all I was just mentioning it as an add-on, just as an adjunct. To have a central repository would be invaluable, but it's incumbent on us to really use them, to make sure that they're every quarter or every half a year they're reviewed. So you're exactly correct.
Thank you, Alan. I was of the same impression too.
This is Jeff Rich. The other challenge that we had at Centera is traveling nurses. We had so many traveling nurses. I'd come in the morning and ask why the patient wasn't extubated, according to protocol, and they would just look at me and say, "What protocol?" It's to Ellen's point, it's the translation of knowledge and keeping up with the staff. It's not only staff turnover; it's the travelers that are being used, more and more in order to fill spots that are vacant.
Well, fantastic points, and we can add same-day discharge to our list of quality measures to start tracking and call for protocols as well.
Not sure how we're making
Megan has an interesting comment in the chat where she says they've had some very strong travelers to initiate changes. So it's good that goes both ways. So the final couple slides are from our STS adult cardiac database. These are actually not our standard quarterly report metrics. We will have the quarter 1 2024 data out very shortly. Instead, we're going to show a couple of slides which were developed in partnership with the MST-CVS, the Michigan Society for Thoracic and Cardiovascular Surgery. These are longitudinal views of data, and it kind of goes back to the discussion of protocol adoption and tracking changes over time, where we're looking at really the last 23, 24 years worth of data. They're grouped initially by 5-year and 6-year intervals, and then we're looking at the last 3 years along the right side of the graph. We're comparing the Northern New England group in green here against our 17 VCSQI centers in red, and then Michigan is shown in blue with the STS 2020 benchmark here as the red triangle. And a lot of these show how sustained improvements have been made over time in terms of these different quality areas. Our first up is red blood cell transfusion over time. This is any red blood cell unit intra or post-operatively. So in the early 2000s, we were looking above 40%. And we've since gotten between 20 and 30% for VCSQI and a little bit higher in Michigan, but still significantly lower than where they started out. Another benefit of these slides is we can compare against another regional quality collaborative. So VCSQI versus MST-CVS, red versus blue. Here is reoperation for bleeding over time. We see again a decrease compared with historical rates, and then a little bit of up and down between a 1.5% and a 2%. Looks pretty comparable between our two states and as well as the STS 2020 average that we have. Along ventilation over time, we've seen sustained improvements. VCSQI comes in just a little bit below MST-CVS over the last couple of years. And even as recent as 2006 to 2011, we were in the 10% range. So that's nearly a 50% decrease. Postoperative stroke. So this is one that's been relatively flat. But still relatively low incidence, between 1% and 2%. And we also have renal failure. So this is stage 3 AKI, which has dipped from the historical data, especially for VCSQI, where we were at nearly 4%. And we're down to a little bit over 2% in the most recent years. So that's a high-level look at our latest VCSQI data, and your suggestions, your questions are most welcome. So thanks all for listening and for sharing your ideas. Any other questions, comments from the team tonight?
Yeah, that's a great presentation of the data there, Eddie. Thank you.
Great job, Eddie and Sherri. Thank you very much.
Well, thank you, everyone.
Agreed.
Thank you to all of our presenters tonight. We deeply appreciate you all as our VCSQI members as well. Thank you so much for everything you do for our group, for all the impact that you help us to have across improving cardiac care in the Commonwealth of Virginia. Wishing everybody a safe and wonderful summer. Please share your feedback with us, your suggestions for how we can improve. And thank you all again. Have a great evening.
Bye-bye.